I'd now like to invite the next speaker, Dr. Rahul Bafna, for a management of a case of acute corneal hydrops.
So, good morning everyone. My talk for today is management of acute corneal hydrops. So, I'll start with a brief case summary. A 12-year-old boy presented to our emergency department with sudden onset of pain, photophobia, decreased visual acuity, and vitis opacification in the left eye for the past 3 days. Parents gave history of rubbing of both the eyes for the past 4 years. On clinical examination, we can see an area of corneal edema of approximately 6 mm with multiple intrastromal fluid vacuoles, and ASOCT revealed a ruptured descendant membrane. Our diagnosis was both eye VKC with keratoconus with left eye acute corneal hydrops. We planned left eye 14% C3F8 intracameral injection under general anesthesia and right eye cross-linking on a later date. We started patients on topical steroid, hypertonic saline, lubricating drops, cycloplegic and anti-glaucoma and antibiotics. On the day of surgery, isoexpansive concentration of C3F8 was used and anterior chamber was filled up to 2/3 of the AC. The same medical treatment was continued in the post-op period. So this is the post-op day 1 image showing that the AC is filled with the 2/3 of gas. We can see there is some gas bubbles have entrapped in the stromal lamellae. It is because of the large descendant membrane tear. On post-op day 18, we can see there is a complete resolution of corneal edema with corneal scarring. So what is a corneal hydrops? It is nothing but a tear in descendant membrane which results in leakage of aqueous into the stroma and epithelium. Its incidence in keratoconus is around 3% and in PMD and keratoglobus is around 11%. The risk factors include eye rubbing, young age, vernal keratoconjunctivitis, atopy, Down syndrome, mental retardation and trauma. In our case, the patient was young with a history of eye rubbing. So, how does this acute hydrops develop? Because of vigorous eye rubbing, which is an inciting factor, results in tear in descendant membrane, which cause rolling of the edges and the gap is created. Aqueous then percolates into the corneal stroma, resulting in the separation of collagen lamellae. On later date, adjacent endothelium tries to grow over the defect so that they can prevent the seepage or and cause resolution of corneal edema. Normally, without treatment, resolution of corneal edema may occur between 5 to 36 weeks. Recently, Parker et al. Has published that only descendant membrane rupture is not the root cause for corneal hydrops. It is descendant membrane rupture along with the posterior stromal lamellar disruption which causes the corneal hydrops. So complications of corneal hydrops are corneal scarring, corneal neovascularization, corneal perforation, corneal pseudocyst, infective keratitis, and corneal fistula. Whenever there is a deep corneal neovascularization, there is an increased chances of graft rejection in the future keratoplasties. Treatment options are basically conservative and surgical. Conservative, as described earlier. Coming to the surgical management, over the years, the treatment modality has changed. 20 years back, 25 years back, when we are managing conservatively, it took around 2 to 4 months for the corneal edema to resolve. There was increased scar formation, there was corneal neovascularization, perforation or keratitis. Now, with the new techniques, we can actually manage them. We can hasten the resolution of corneal edema within 6 weeks. Even we can visually rehabilitate the patient within 2 weeks. 2 weeks. So surgical management strategies are basically 4. In the first strategy, we either seal or approximate the descendant membrane tear, which results in prevention of further egress of aqueous into the stroma and hasten resolution. Or we can replace the toned descendant membrane with normal endothelium, but it is nothing but the replacing pathological descendant membrane, and we are maintaining the endothelial integrity. The latest one is the replacing the edematous stroma, by which we can visually rehabilitate the patient. And in patients with painful eyes or with no visual potential, we can do biological covers like amniotic membrane transplant or Gunderson flap. So let's see the first strategy. That is seal or approximate the descendant membrane tail. Miata et al. In 2002 has done the first surgical intervention acute corneal hydrops, where he has injected just intracameral air. The resolution time was halved from mean 64.7 days to 20.1 days. But the problem was the patients required number of injections, and the average number of injections were 2.4. Later, people start thinking of using gases which can have longer duration of half-life. So, Panda et al. Use SF6 gas, which is an intermediating long-acting gas, but in this also the resolution was within 4 weeks, but 66% of patients required repeat injection. Later, Sayan Basu et al. Used long-acting C3F8. In this, the resolution time was halved, and none of the patient required repeat injection. Then people started thinking that how we can increase the resolution of corneal edema. So people came with full thickness sutures for corneal edema. So with this, the resolution time was 4 weeks, but there were complications like deep vascularization, Siedel's positiveness, and recurrence. Then people used mix and match. People started using MIOC guided drainage of acute corneal hydrops along with gas suturing. With this, the resolution of edema came down to less than 2 weeks. Later, people like Vajpayee et al. Use ASOCT for the management of acute corneal hydrops. Here, they have localized the fluid vacuoles using ASOCT and just puncturing the fluid vacuoles and just injecting intracameral air. So no repeat injections were required in such cases. Now now the surgical techniques are more evolved. Now this is a prospective randomized trial. The compression sutures combined with intracameral air injection versus thermokeratoplasty for acute hydrops. In both the groups, the resolution of corneal edema was within 2 weeks. So by now we know that combination of techniques resolve the corneal edema as fast as less than 2 weeks. People then started thinking how to visually rehabilitate the patient as early as possible. So people have started doing thermokeratoplasty, that is cauterization of the corneal stroma. Then later, after 2 weeks, they perform early DALK. By this method, the patient attained visual acuity of 20/60 of 1 year follow-up. The next strategy is the replacement of the Descemet membrane. Only few case reports have been reported. They have used DSEC, DMEC, or mini DMEC to actually restore the integrity of the endothelial layer. So we have not much data regarding this. Later, this is the recent one where we replace the edematous stroma. We do DALK on the presentation, and patient gets the visual acuity of 20/50 within 2 to 3 weeks. So take-home message is very important. You should always identify the risk factors, counsel the patient regarding the same, about the follow-up. Combination of various techniques always helps to hasten the resolution of corneal edema, and newer modalities of treatment for early visual rehabilitation of patients should be adopted as early as possible. Thank you.
Thank you, Dr. Rahul. That was a very systematic and a very comprehensive review of the literature. May I ask the audience how many of us have treated cases of corneal hydrops? A show of hands, please. Okay, so it's because, again, it is something which need not remain in the realm of a cornea, just a cornea specialist. It will come to the comprehensive ophthalmologist. And just a couple of tips, which because you mentioned like in your case, you showed just the gas injection, but you've shown so compression sutures plus gas injection works very well. It could depend on your stepwise approach. If the edema is not so much, maybe just a gas injection would suffice. On the other hand, if it is too much, compression sutures do work well. Preoperatively, before we take up the patient for surgery, I think a good dilated examination to see the direction of the tear in retroillumination. If one has access to an ASOCT, then a scan and seeing the direction is great. But even if one doesn't have that, dilate the pupil, try to do a retroillumination kind of a thing, and you would be able to see, is your tear directed this way or is it directed that way? And then your sutures need to be perpendicular to that. So dilate the patient, before you're taking up the patient for surgery 1 day prior, but on the day of surgery, do constrict the pupil, use pilocarpine beforehand so that you don't damage the lens, because once one is passing the sutures, there is a high risk of damaging the lens. The direction of the needle needs to be completely vertical, unlike what you do in normal suturing where it is a little tangential. And often injecting a little bit of air before passing the sutures helps to see the reflex of the needle well, and suturing does that. And you mentioned about the SF6 and the C3F8. My personal preference now in all cases, even in DSEC and all, has shifted to using SF6. Air, I feel, sometimes tends to disappear too early, and C3F8 remains too long, and it causes the risk of cataract. So SF6, I think, works very well, and it is a good borderline thing between, to manage cases of conservative management with medication. I think is very, very few cases. So I think we need to be aggressive about the treatment of hydrops. But whether we need to be as aggressive in doing the DALKs and all as quickly, that I would definitely have my reservations about. I think there's no harm in waiting a little bit while doing this. So any other comments from the audience regarding this? Thank you. So that was a good
Thank
talk.